Um, Thank you again for the introduction and for inviting me to speak to you today about neuropathic pain after spinal cord injury. Throughout today's talk, I'll be reviewing a management protocol for neuropathic pain in the context of our campaign SCI 2021 Clinical Practice Guideline Update. Before we get started, I'd like to acknowledge the steering committee and the expert panel members who are involved in developing both the original guideline and the update, and for their work to continue moving these guidelines forward. I also want to acknowledge the Ontario Neurotrauma Foundation, who had funded both the original work and the update, and also to the Ministry of Health, who has provided funding for ongoing work with regards to the guideline. Unfortunately, I don't have a link to share with you in terms of the guideline itself, as it is still under review at the publication, but I will be speaking to the findings of our expert panel and our guidelines development process today. The original guidelines were published in 2016 and focused on those with spinal cord injury who were either in the rehabilitation phase of their management or living in the community. Because of the amount of time that had passed since the original guidelines, it was felt important to provide an update of the guidelines in 2021. The original guidelines focused on screening and diagnosis, treatment options that were both pharmacologic and non-pharmacologic, as well as models of care for delivering care to those with neuropathic pain after spinal cord injury. The objectives of today's talk will be to discuss neuropathic pain management after spinal cord injury within the context of the guidelines that have been developed. I'm going to review key changes in our current guidelines, as well as highlight key recommendations that are present both in the present guidelines and the previous version of the guidelines, which will give people hopefully an overview of recommended practices for neuropathic pain management. I'll also describe some of our implementation plans and next steps with regards to the guidelines. If we take a step back and examine why we had developed these guidelines in the first place. As you are all aware, neuropathic pain is common after spinal cord injury and can be difficult to manage. At the time that the 2016 guidelines were developed, there was really a lack of any specific guidelines or recommendations in terms of managing neuropathic pain after spinal cord injury. Much of the guidelines that existed at that time were taken from general neuropathic pain guidelines, which addressed central neuropathic pain conditions and not spinal cord injury in general. Even within those guidelines, a lot of the recommendations that were given were based off of peripheral neuropathic pain populations, for example, those with diabetes or any other type of peripheral neuropathic lesion as a cause of their pain. If you look at those guidelines, when talking about recommendations for central neuropathic pain, many of these guidelines often put in a caveat to just look at our peripheral neuropathic pain guidelines to provide guidance. And part of that is reflective of the lack of evidence that is present for central neuropathic pain conditions and recommendations for treatment. When we had asked a number of healthcare practitioners across Canada whether they felt there was a specific need for guidance and recommendations in terms of neuropathic pain after spinal cord injury, the vast majority of people who responded acknowledged that there was a need to standardize care after spinal cord injury, both given how difficult it is to manage and also because of the lack of guidance that really existed at that time. So the original purpose of the guidelines was to create practical, actionable guidelines in the management of neuropathic pain after spinal cord injury. to support standardization of care, and also to identify and itemize deficiencies in our current knowledge and the current evidence base with regards to managing neuropathic pain. To do so, we set limitations on the type of literature that we would look at and the type of evidence that we would evaluate. So when looking at the literature, we would only look at evidence reviews which focused on the spinal cord injury literature. Essentially, over 50% of the population in a particular study that was to be included had to have a spinal cord injury, be at least 18 years old, and the study should have examined either neuropathic pain or a mixed pain population. So any study that looked specifically at MSK pain alone would not be included unless they included a dimension of measuring neuropathic pain as well. The key outcome we looked at was pain intensity. So that is a bit of a limitation of the study, as pain intensity is not the only measure that can guide treatment selection or the success of certain treatments. But to have a standardized approach, and for the initial phase of the guidelines, we looked alone at pain intensity. The other key component of our guideline development was that it was developed in accordance with the Agree-To tool, which is a standardized methodology and a standardized system of approaching the development of guidelines for neuropathic pain. So in the next few slides, I'm going to present the initial recommendations that were provided in our original guideline. Again, these domains were screening and diagnosis, treatment, and models of care. Here we have the screening and diagnosis recommendations in the initial guideline. There were 12 recommendations, and they were listed as expert opinion. In the 2021 guidelines, these current recommendations were not modified, but we did add a number of recommendations based on new literature in the past few years. So the screening and diagnosis recommendations really outline the steps that should be taken when you see someone with spinal cord injury in terms of managing pain or potential pain. The screening and diagnosis recommendations can be grouped into kind of different categories. The first three recommendations really examine or really highlight the need to screen people with spinal cord injury for neuropathic pain, given how common it is. That screening should occur on admission and regularly during inpatient stays, as well as discharge on follow-up. The next few recommendations deal with the assessment of a person who screens positive for neuropathic pain, and what steps should be taken in terms of assessment, and what tools should be used to document that person's pain and functional impairments as a result of their pain in a standardized way. And the last few recommendations here outline when reassessment should be done and how often treatment response should be evaluated by the healthcare team. So when approaching someone who does screen positive for neuropathic pain, what are the steps that need to be done, and what are the domains that need to be assessed and documented? So the approach to neuropathic pain should look at the nature of pain to start with, and those are your standard questions for any type of patient or person who presents to you with pain, such as onset, position, what the pain feels like, the severity, etc. The next aspect of the assessment should be assessing changes in neurologic status. So if there's any new weakness, new numbness and tingling, changes in spasticity, changes in bowel bladder habit, etc., those should be assessed as part of a neuropathic pain assessment. Associated symptoms and signs, particularly red flag indicators, should be assessed. Musculoskeletal changes, skin, cardiovascular changes, etc. The impact of pain on different aspects of function, sleep, mood, and emotional function need to be addressed as well. As I mentioned earlier, it's not just the pain, but the impact of pain on function and daily life. The other thing that should be documented and asked about is any recent changes in health, such as new medical diagnoses that might predispose someone to neuropathy and developing neuropathic pain. In terms of the assessment, when talking about and when assessing red flag conditions, the expert panel in the original guideline had come up with this chart which identifies different systems that could be involved, different indicators that might point to specific involvement of different systems and what red flag conditions may contribute to neuropathic pain in different contexts based on presentation. So for example, if we take the musculoskeletal system, if there's been a history of recent trauma or a visible deformity, you may have to think about things like fracture or dislocation, which may exacerbate or cause neuropathic pain in a particular person. If you go through this chart, much of it seems to overlap assessment for things such as autonomic dysreflexia, but it's always important to look for things that could be managed or need to be addressed in the context of a person's pain presentation. In the original guideline, we had also presented a number of yellow flags. So these conditions or these yellow flags may complicate recovery and may complicate the management of neuropathic pain after spinal cord injury. And there's a whole list of things that could be impactful on a person's pain presentation, such as mood, changes in appetite, poor motivation, substance use and dependence, etc. Which need to be assessed and documented, as they may impact how a person responds to management and the types of things that need to be looked at when trying to optimize a person's management if they have pain after spinal cord injury. So that's the screening and diagnosis portion of the original guideline, and as I stated before, there was not much change or modification to those existing guidelines, although a few guidelines recommendations were added, and I'll review those in just a little bit. The next section that we looked at in the original guidelines was with regards to treatment. So we looked at both pharmacologic and non-pharmacologic treatment. This particular section had the biggest change in our current guidelines. When we had originally presented the guidelines, we had presented a stepwise approach, looking at first line, second line, third line, fourth line therapies, etc. It was felt that there wasn't enough specific guidance or specific definition in terms of how to use that information. And there was quite a debate amongst the expert panel that this is likely not the approach that most people would take in terms of managing neuropathic pain. So we did change the format of how this was presented in the new guidelines. And I will present that in a little bit, but I just wanted to in this slide just show you what the original recommendations looked at and how they appeared in the original guideline. In the original guideline as well, there were a number of treatments that we had looked at that the expert panel felt was not appropriate to make a recommendation for. And these things included visual illusion, exercise, acupuncture, etc. There's a whole list here. And there were a number of reasons that no specific recommendations were made in the original guideline, including a lack of long-term follow-up for certain treatments, and this applied specifically to the IV treatments such as IV ketamine or IV lidocaine. There was low-quality evidence of a positive effect, so the expert panel felt that there wasn't enough there to make a specific recommendation. Some of these treatments did have a positive effect that was demonstrated in other populations, but not specifically in spinal cord injury. So again, because of the definitions that we had laid out initially, we didn't make specific recommendations on those in the original guidelines. And in some of the treatments that were looked at, there was conflicting evidence of positive effect, to the point where even despite meta-analysis looking at those specific treatments, if one could be done, the panel decided not to make a recommendation for some of these treatments. In terms of the last section, which was models of care, this section didn't change at all in our current guideline. There wasn't any new evidence that was available that would have changed the recommendations or caused us to add additional recommendations. If we're looking at models of care recommendations kind of in general, basically what they were addressing was that it's important to address both functional and psychological impacts of pain, because for those with chronic pain, even those who don't have a spinal cord injury, complete alleviation of pain is usually not a realistic goal. Oftentimes you're looking at improving people's function or improving their quality of life rather than trying to completely alleviate their pain. To that end, the guidelines did emphasize the need for a team approach to provide timeliness of treatment. The team approach involved both kind of specialized SCI clinics as well as chronic pain clinics, and that there was a need to coordinate between those two types of clinics to effectively manage more complex functional and psychological impacts. The original models of care recommendation did emphasize the need for alternate communication methods when distance was a barrier. Of course, with the pandemic, I think we're much more comfortable or developing a comfort with those alternate communication methods, more so than when the original guidelines came out in 2016. The original recommendations also laid out criteria for discharge from specialized care, specifically when a stable plateau in symptoms and maximal functional gains were achieved. So that's essentially what the 2016 guideline had originally presented, and as I mentioned, we had recently undergone an update for the guidelines in 2021. There were a number of expert panelists from across Canada and internationally who participated in the process. They had a number of different backgrounds, either different types of physicians, such as physiatrists, a neurologist, a number of non-clinicians, such as research scientists, basic scientists. We also included those with lived experience. Other clinicians were also involved, from physiotherapy, occupational therapy, and pharmacy, as well as nursing. And we tried to capture as many people across Canada as we could in different provinces, but we also had international members as well from Australia and the United States. The guidelines were also evaluated by a number of external organizations, such as SCI Canada, the Pain and Spinal Cord Injury Special Interest Group at the CAPMNR, as well as the Canadian Spinal Research Organization. And those organizations had provided endorsements for our guidelines as well. So when we looked at the updated literature, there were a total of 43 new studies within the treatment domain that we looked at. 3 studies in screening and diagnosis, and no studies that we identified within the models of care domain. So this literature really informed modifications and updates to the recommendations in our 2021 guideline. So within the screening and diagnosis recommendations, as I had mentioned previously, the 2016 recommendations, the existing recommendations were not modified, but we did add to those recommendations, and these are listed here. So in our update, the panel recommended that the spinal cord injury pain instrument and the neuropathic pain symptom pain inventory could be used to supplement the diagnosis of neuropathic pain for people with spinal cord injury. Both of these tools were found to have reasonable sensitivity and specificity, both against a numeric rating scale for pain severity for the NPSI, and also for the multidimensional pain inventory, again, for the NPSI. The studies that we had looked at for these new tools were relatively small, so they weren't sufficient to change or replace the current tools that were recommended for screening, specifically the basic pain data set. However, these would be additional tools and criteria to consider for neuropathic pain after spinal cord injury. Again, the other recommendations follow along with those concepts. So the NPSI can be used to supplement assessment and documentation of neuropathic pain, and the NPSI can be used to supplement evaluation of treatment response. The biggest changes that we had within our current guidelines was within the treatment recommendations. In 2016, you'll remember that everything was presented in a stepwise pattern. In 2021, there was a major restructuring of the treatment classification, which was suggested by the expert panel. The expert panel also felt that it was important to include key treatment principles to inform clinical practice and to make those a key component of the updated treatment recommendations as well. Now, within the 2016 version, we had proposed a stepwise treatment approach with first, second, third, and fourth line. This was based on both the quality of evidence and the strength of recommendation. So if something had a high quality of evidence and a strong strength of recommendation, it was first line. Conversely, if it had a weak recommendation and only a moderate or low quality of evidence, the treatment was automatically slotted in as fourth line. A number of issues with that approach were raised by the expert panel at our current meetings. Basically, a lack of clear guidance for treatment selection was found to be limiting. So the panel didn't feel that it was necessary or appropriate to have exhausted all second-line treatments before moving on to a third-line treatment. And I think when we looked at the stepwise approach, this wasn't really something that people wanted to emphasize either. Really, selection between second and fourth-line treatments might be based on other relevant factors. And it might be appropriate to trial something that's third line or fourth line before second line based on a number of other considerations. And this could include things like patient preference, shared decision-making, tolerability, clinical experience, and side effect profile. The one thing that the panel wanted to make clear was that first-line treatments such as pregabalin, gabapentin, and amitriptyline should always be considered initially, but that when you reach second, third, and fourth-line treatments, you could choose something, say, that's third-line before something that's second-line. Now, although the approach for second or previously second to fourth-line treatments was non-hierarchical, the expert panel felt that there still should be a distinction between those groups of treatments because there is some difference between levels of evidence and strength of recommendations proposed by the panel, which might influence people's decision making one way or the other. And it was felt important by the panel to provide some clarity and additional information to the user so that they could consider this within their decision making. So basically, as a result of that change in approach, this is how the guidelines look currently if you look at it in a table format. So basically, these are the principles of management at the top that were proposed by the expert panel. Following this are first-line treatments that should be considered. And finally, the second or formerly second, third, and fourth line treatments. Now, the previous second line treatments were reclassified as B options. The third line treatments were reclassified as C options, and the fourth line treatments were reclassified as D options. And the wording was made consistent between each of these specific treatments. So in terms of B options, the following can be used. For C options, these treatments may be considered for neuropathic pain after spinal cord injury. And similarly for D options, the following may be considered for neuropathic pain after spinal cord injury. And as you can see from the table as well, the way it's illustrated, we tried to emphasize the point that you might choose to go between these B, C, and D options, not necessarily in order, but based on consideration of a number of other factors. So when we look at the top part of that diagram, basically the principles of managing neuropathic pain after spinal cord injury, these are the specific recommendations that were agreed upon. So the first recommendation is that those with neuropathic pain after spinal cord injury should be encouraged to pursue self-management strategies that they may find beneficial for pain intensity reduction, coping with pain, and improving function. This recommendation is born from the fact that the consensus panel acknowledged that the overall body of evidence for neuropathic pain after spinal cord injury is limited to start with. There are a number of strategies that someone living with neuropathic pain may find beneficial for coping with their pain and improving their functioning, such as hypnosis, exercise, massage, yoga, acupuncture, peer support, etc. Now, these specific modalities aren't recommendations within the guidelines, and that could be for a number of reasons, such as a lack of evidence, specifically in those with spinal cord injury, and also non-existence of evidence. But the panel felt it important that if someone found it useful, that they shouldn't be denied this treatment because of that specific lack of evidence. But that has to be considered in discussion with their healthcare provider. The second recommendation is that a comprehensive pain management strategy should also address issues with activity, sleep, and mood that may be a result of their pain. Again, even with optimal management, neuropathic pain intensity might not significantly change. So it's important to address whether the management is impacting activity, sleep, or mood. And those domains should also be addressed specifically when managing someone's pain. Because ultimately the goal is to improve someone's quality of life and to have them better manage with their pain. The third recommendation is to consider referral for expert multidisciplinary SCI rehab management to address specific functional limitations, but that might depend on the resources and expertise available in a person's clinical context. Number 4 was that an interdisciplinary pain program might consist of patient education, CBT, self-management strategies, group discussions, exercise, etc. And again, that depends on local contexts and what specialized pain treatment services might be available either within or outside of an SCI rehabilitation program. So the expert panel just wanted to make sure that that was emphasized. And the final recommendation in that top box was that CBT should be considered to improve coping skills and reduce pain interference. Now, although CBT hasn't been shown to improve neuropathic pain intensity after a spinal cord injury, it can reduce pain interference. So the panel considered CBT an important part of a comprehensive management plan for neuropathic pain after spinal cord injury. So when we get to the bottom part of that table, we get into specific treatments that were recommended by the expert panel. And when we look at those first-line treatments, pregabalin and gabapentin are still considered first-line, and these medications should be used in the treatment of neuropathic pain after spinal cord injury. Of all of the treatments that were evaluated, pregabalin and gabapentin have the best evidence, and that did not change with further review of the evidence in the new time period. Amitriptyline is listed below pregabalin and gabapentin, and the main reason for that is that amitriptyline should be used with caution after spinal cord injury because of its anticholinergic properties. So effects, say, on bladder or bowel function, which may impact someone with spinal cord injury quite significantly, needs to be considered and discussed as a risk. Now, if we look at the B options, which were formerly the second-line treatment options, these included oxcarbazepine, lamotrigine for incomplete spinal cord injury, and tramadol. Oxcarbazepine was a new recommendation that the panel had included. And they had included this particular treatment because of a single high-quality crossover study, and compared to the existing second-line treatments from the 2016 guidelines, namely lamotrigine and tramadol, oxcarbazepine was felt to have a favorable side effect profile. When using this medication, certain things need to be considered. Basically, the risk of hyponatremia, particularly within the first 3 months, especially if used in combination with an SSRI or diuretic. The other factor to keep in mind is that it's a weak inducer of CYP3A4 with potential to decrease the effectiveness of medications such as the oral contraceptive pill. So that needs to be discussed with people that you may be considering using this medication for. Previous existing recommendations were tramadol, for which there were no new studies in our updated literature search, and lamotrigine. The question that the panel had for lamotrigine was whether to expand the treatment recommendation beyond those with incomplete spinal cord injury to those with complete spinal cord injury. In one new moderate quality longitudinal study that looked at lamotrigine versus amitriptyline, over 3/4 of the patients in this particular study had a complete classification, complete motor sensory classification, but there was no difference. And there was no difference between those who received amitriptyline versus lamotrigine. There was only a 3-week follow-up period, and it was an unblinded treatment. So for these reasons, the panel felt that there was not enough evidence to change the recommendation from incomplete to all spinal cord injuries. So the recommendation from 2016 was kept as is. The next group of treatments were the former third-line options, or the C-line options, in the 2021 guidelines. And the new recommendation within these C options was botulinum toxin A, which might be considered in those with below-level neuropathic pain. The injection should be done in the area of maximal pain. This was based on one high-quality RCT, but there was a weak recommendation for this particular treatment. In this single study, there was a significant reduction in pain at 4 and 8 weeks compared to placebo. There were a number of drawbacks with the study. It was a smaller study, and the effect on those with different levels of injury and different completeness of injury also needs to be assessed. So for that reason, the panel had given this a weak recommendation. And now we get to the former fourth-line options, which are really D options in our 2021 guideline. Again, these treatments may be considered for neuropathic pain after spinal cord injury. The one new recommendation amongst this grouping was cannabinoids. Again, cannabinoids could be considered, or may be considered for the management of neuropathic pain amongst persons with spinal cord injury. Again, this was based on one moderate quality crossover trial, which demonstrated decreased pain intensity at 7 hours. A number of drawbacks with regards to the study was the lack of a dose response or a graded analgesic response with higher doses. It was felt that cannabinoids had a favorable side effect profile compared to existing D-option treatments such as oxycodone. The panel emphasized that there certainly needs to be further research with regards to cannabinoids, but that they may be a reasonable option. Now, there may be a number of treatments that were evaluated, but were felt again by the expert panel not to require a new recommendation. And there are multiple treatments that fit that criteria. Things like intermittent neuromobaric hyperoxia, neurofeedback training, anti-inflammatory diet, breathing-controlled electrical stimulation, etc. That for a variety of reasons, it was felt too early for these treatments to be yet considered as specific recommendations. But in future, with more studies, that may change. But for the time being, this list of treatments was evaluated for quality, but it was found that there just wasn't enough there to make a specific recommendation at this time. The other limitation with regards to the guidelines that the panel wanted to address was, how do we make this more relevant and more accessible at the bedside? You know, during a clinical encounter, how do we make these recommendations more applicable and more likely to be used in a clinical context? That was part of the reason that they had driven for a renaming of the second, third, and fourth line, and more specific definitions of how those were to be used. As a first step to try and make these guidelines more applicable to clinical care, a specific algorithm was proposed to summarize the key findings of our recommendations. So instead of presenting it merely as a textual document, developing a visualizable algorithm was important. From this algorithm, we could hopefully develop clinical tools or apps that can help guide clinicians through choosing different treatment options, through assessing and documenting neuropathic pain, and to ensure that the management, both from a diagnostic and treatment perspective, is broad-based and covers all the necessary components. So within this algorithm, we've included kind of the screening and diagnosis elements at the top, and then the treatment recommendations at the bottom. And then within these specific areas, such as new or worsening neuropathic pain that needs to be addressed, the specific components of the assessment that should be considered are also presented within an algorithmic format. Now, this is still challenging to use and less accessible to most clinicians. But I think using this as a starting point to inform app development or development of clinical decision-making tools is important. So we've taken this initial step to do this. A lot of these kind of step-by-step approaches were based on work previously done by Dr. James Middleton in Australia, and also an updated version of that initial algorithm by Dr. Tom Bryce in the US. So we are working with them to take the updated recommendations to inform those algorithmic approaches, and ultimately to inform online-based tools or other tools that could be used to communicate the recommendations kind of at point of care. So really that informs kind of our next steps in terms of integrating the guidelines into a clinical point of care. If you're interested in looking to kind of just go through a preliminary version of that, there is a version available in Australia, and the website is listed here, and I can send it out if needed, where you can kind of look at how that approach would work. We're presently trying to adapt that to a more Canadian context, and hopefully we'll be able to evaluate the use of those tools in different contexts, either in the community, in family doctors' offices, or in an outpatient rehabilitation setting, to see how useful it is in terms of standardizing care of neuropathic pain after spinal cord injury. The other step that we were looking to take is to examine a living guideline update of the guidelines, such that whenever new literature comes out, we can respond very quickly to that and provide a relevant version of the guidelines that can be used consistently, rather than waiting the 3 to 6 years before doing a formal update of the guidelines, so that whatever tool you're using in terms of trying to make clinical decision making, to the best of our ability, it's as up to date as it can be. So that's the guideline update in a nutshell. There are a number of things that we need to keep in mind with regards to the guidelines as I've presented them. Number one, pain intensity was specifically evaluated. Now, although that's important to look at pain intensity, it certainly isn't the only option or the only factor that you're considering when managing neuropathic pain after spinal cord injury. You need to look at sleep, mood, function in general as it relates to their pain and how they're responding to treatments in that way. When we look at the literature, pain interference as an outcome isn't consistently measured across all studies, which made evaluating that a bit more challenging within the guidelines. We are hoping to more formally incorporate that in the future, but that is one caveat you need to keep in mind. The other caveat is that the recommendations aren't to be used in isolation from each other. Combination therapies can certainly be beneficial for your patients, but different combinations of therapies have not been specifically evaluated in the literature very extensively. Finally, the overall evidence for neuropathic pain management after spinal cord injury is very limited, even for our first-line treatments. So you have to take the recommendations with that in mind. If we were doing a guidelines on diabetes management, the types of sample sizes that we were looking at in these studies would not be appropriate or not meet criteria to be included in a recommendation or in a guideline of that nature. But because of the small population size relatively of the spinal cord injury population, we are limited by the types of studies that we are able to assess and that provide us with specific information to this population. I think this was debated extensively by the expert panel as well, because the amount of time that it will take to have evidence to the degree that would give you a high confidence on the grade rating scale as it's initially or as it's conceived would take years, if not decades. And we need some sort of guidance to help our patients now. So the guidelines, I think, reflect that lack of high quality evidence overall, and try to incorporate a bit of practical clinical considerations to give people guidance on how best to manage and help people with spinal cord injury despite the limitations in the evidence. In conclusion, there were 3 new recommendations for screening and diagnosis and 8 new treatment recommendations in the 2021 guideline. The key change for the guidelines was that the treatment recommendations are now presented in a less hierarchical manner, and that really reflects the state of the evidence. And finally, we're trying to develop an algorithmic format to guide the development of point-of-care tools, and that's really where we're heading next with the guidelines.